to think about how treatment of pediatric femur fractures works is basically based on age. And so, if you go 0 to 6 months, basically most people, the evidence would say that you could do either a spica cast or a Pavlik harness, but that there's really no advantage of the spica cast over a Pavlik harness. So most people will use a Pavlik harness. The ability of the femur to remodel at that age is remarkable. So there's really no reduction performed. And the Pavlik harness is predominantly for comfort measure while the femur fracture is healing. So so that's 0 to 6 months. And then as we move forward, 6 months to, let's say, 5 years, we're basically looking at spica casting being the gold standard. There's some that in certain situations, whether that be high energy trauma or, other psychosocial or social needs for the family, will consider flexible nails in some of the slightly older preschool kids. But again, the gold standard is spica casting there based on the age criteria. And then age 5 or 6 to about 11, we would be looking at flexible nails. Okay, now if you read a book chapter, it'd be flexible nails for stable fractures and consideration of a submuscular plate for unstable fracture patterns. In my practice, it basically jumps from spica cast to flexible nails to rigid nail. And we kind of skip over the submuscular plate for me. But there are other, and that's mostly here at our institution. And I know at some other institutions, it's pretty flex nail heavy. There are other institutions and other surgeons, who have a bigger interest in submuscular plating. And then for kids that are bigger, and as we get into the adolescence, we're looking at rigid nails. Similar to adults, the only difference is that the entry point is slightly different, where we avoid a piriformis starting point due to the risk for avascular necrosis. So, for a general overview, that would be sort of the age-based treatment algorithm.
Okay. And if we could go back a little bit to, say, starting at the kid that's less than 6 months old. So in the emergency department, mom is just, she is, she can't believe this happened. She's so sorry that she turned her head for a second and baby Joey fell off the bed or whatever may happen. Like, what are some of the things you're telling mom to look for once the kid is in these different devices like the Pavlik harness? What are some of the things that you may tell mom that, okay, this is how this is going to go, and we'll probably have him in this for how long and things like that?
Okay. So for somebody that's that young, honestly, they're going to heal almost basically in like 2 weeks, but I'd probably keep the Pavlik on. I generally keep it on for about 3 weeks, see them back in clinic, and we'll take it off. I emphasize that it's for comfort only. And, some of the positional issues, and I see that's on your slide, whether you use a Pavlik harness for developmental dysplasia of the hip, or if it's for a femur fracture, there are a couple things that you want to avoid. You want to avoid flexing the hip too much in a Pavlik harness, okay? And the reason is because if it's flexed too much, you can get femoral nerve palsy. The thing that we would notice with that would be that you'd have decreased quad function. So, a 6-month-old is not going to follow an exam to command, but, you observe them in clinic, and even in the Pavlik harness, they should be able to extend and flex their knee, and you'd be able to observe that. So that'd be one of the things that they would want to look out for. And then the other thing is, you don't want to have too much abduction fixed into the Pavlik harness, because if you have too much abduction, or if it's too tight, then that can lead to avascular necrosis of the femoral head. And, from my perspective, you got to keep in mind that, again, like I said from the beginning, when it comes to the Pavlik harness, our treatment is for comfort. So if the only reason we're using the Pavlik is mostly for the infant's comfort, we certainly want to avoid making it too tight, either too tight in hip flexion or too tight in abduction. So if anything, you would want this Pavlik harness to be, looser than it needs to be, as opposed, error on the side of it being too loose as opposed to it being too tight. Because unlike DDH, where you're kind of using the Pavlik to mold the femoral head and the acetabulum, and it's like being used as a tool, this is kind of being used as an ACE wrap almost, or a very mild splint. So, with that in mind, you certainly don't want to end up with a femoral nerve palsy or AVN.
Absolutely. And I saw one time, if you happen to have one of these kids that's just an all-star and for some reason they're like crawling at a really young age, you might have to think of something different than the Pavlik harness sometimes, just to keep them from, running around, crawling around like they want to try. So I only had that happen like one time, but something to keep in mind.
Definitely. But the other point to these kids is that these fractures heal very, very fast.
Which is so amazing to me. I think that's the whole, overall theme in pediatrics. I mean, you put a grocery bag around it and pretty much it heals itself.
Grocery bag.
Yeah, I
That's
mean,
true.
really, you put a Kroger bag on it and I mean, give it a little time and next thing you know, it's like brand new again. It's amazing.
If our ER runs out of Pavliks, I think maybe next time I'll try the grocery bag.
Just tell them get a Kroger bag.
Works like a charm. Works like a charm.
Well,